So we would be discussing about the live demo of one clinical case scenario, and also few of the tips and tricks what we gathered from our last 1.5 year to 2 years of experience from the candidates who have cleared it successfully from tricks 2. We gathered some of the real questions from the examinees who have appeared the test EDIC 2, and they shared from their memory the questions. So that would be really useful what is happening in current time. So continuing further, normally the CCS in the last EDIC 2 exam, which was finished in the May month, 2 long CCS were asked and 2 short CCS, but the marks were from like 3 CCS. So the third CCS would be of 2 short clinical case scenario. Usual time frame for one CCS is 25 to 30 minutes each. Now, the May session questions from the CCS 1, the first one, we have collected the questions. It is a rough idea of that, the flow of the clinical case scenario. It is not the exact case, but yes, the candidates have shared from their memory after just coming from the exam. And we included in today's discussion just to let you know how deep they normally enter into. The examiners want you to know, and the questions can like move from one domain to other domain in like fraction of seconds. So the first real CCS in the last May exam was, it was started, we can divide into it was a central nervous system. The case was a post cardiac arrest. The details were not there in the clinical case Vignette. First 24 hours after cardiac arrest, what was the management? How do you approach? That was the questions. Then the therapeutic target temperature management. So target temperature management was asked in the clinical case Vignette, and then prognostication after cardiac arrest. So those were the questions in the clinical case Vignette 1. And then that patient was brought to your hospital with poor GCS. They have not clearly mentioned that this patient was brain dead. So that was again something confusing for the candidates. But yes, the patient presented post cardiac arrest, initial managed in some other hospital for first 24 hours with TTM. And now that patient is brought to your hospital ICU with poor GCS. How to proceed further? That was the straightforward question in the clinical case Vignette 2. Then there were questions coming like ancillary tests to go for the brain death declaration. What were the interpretation of those ancillary tests? How would you confirm your diagnosis? Then that patient again had hyponatremia. So they didn't like disclose that it was hyponatremia, but yes, the sodium value was 133. So how would you manage further? Then the questions again in the clinical case Vignette 3, the patient is now not satisfying all the criteria of the brain death. The patient was triggering ventilator. So you cannot say that this patient is brain dead. Now, so the questions were revolving around that. So how would you go ahead in like the further 2 days, 3 days? What were the imaging findings? What would be your next approach? Then when you do like discuss about the withdrawal of life support. And finally, the last question was around DCD. So like death after circulatory, donation after circulatory death, in contrast to the brain death. So the questions in the first clinical case scenario, more or less you can say it is a central nervous system in broad domain. But yes, it started from cardiac arrest. So the questions initially were from the cardiac arrest management. It is again a high yielding topic. So you have to be thorough with post cardiac arrest management. Then again, it is entering into the brain death. Again, another important domain you cannot dare to miss before going into this type of exam. And then it ended with withdrawal of life support, counseling, communication, and prognostication and DCD. So that is the, like you can now see the vastness of the questions, and your like the level of preparation has to match with the expectation from the examiners. Any inputs from Dr. Wong at this point of time? Dr. Sanant, anything from your side?
Yeah, that's important because the most important thing here is one can lead to the other. Any scenario can lead to any other scenario. So suppose if it starts as a respiratory case, don't think that it will hover around the respiratory issues and respiratory management. So it can end up very well with something else. So always keep an open mind for the vignette to look for. Suppose a respiratory patient can have a abdominal compartment syndrome and then can have a sepsis and then can have a cardiac arrest with prognostication and talk about hypothermia and all those things. So it can rotate and go in circle, or it can go from one to the other scenario. So most important thing is to keep an open mind.
Yeah. So moving further to the clinical case scenario 2, believe me, these are the real cases. So that would definitely help you to frame your own like question scenarios in your ICU for the practice purpose. And also you should also like start answering these questions and the answers to your fellow colleagues to get the confidence in answering in the real examination. So the second clinical case scenario was something related to surgical domain. So first one was the like you can say subspecialty or super specialty ICU. The second one is the patient with obesity, atrial fibrillation. No further details. It was actually post exploratory laparotomy. Patient presented with to your ICU with a massive blood transfusion, developed DIC, ended up in sepsis, acute kidney injury, multi-organ failure. You have advised for renal replacement therapy, CBP-HD. They were asking about the dose of CBP-HD and then like how you should like anticoagulate that patient, something related to again RRT, which is part and parcel of your critical care. Now, after 2 days, 3 days of initial stabilization, and then the patient had a second hit, and that was again skin and soft tissue infection. And they asked about MRI finding of necrotizing fasciitis. So that was something a little bit not very, you can say people were not very convenient with MRI finding of skin and soft tissue infection. But yes, there was a picture in the clinical Vignette 3. Now, again, you manage that patient, but the patient had a third hit and that patient is not recovering as per your expectation. So how would you prognosticate? So again, you can see the patient initially presented with post-op exploratory laparotomy, and the questions were around the massive blood transfusion, then the coagulation parameter, trauma-induced coagulopathy, ended up in DIC, some blood and blood product transfusion, then developed sepsis, AKI, multi-organ failure, then one of the, you can say, supportive therapy, organ support, that is RRT. So they will be asking you about the everything related to RRT. They can ask you about SLADE, they can ask you about the CRRT. And then some of the complications that the patient develops in your ICU, post-operatively in the surgical ICU, skin and soft tissue infection, and finally ended up with prognostication and again the counseling part. So any inputs from Dr. Wong, Dr. Sanand at this point of time, or any of the candidates, or I'll go ahead with the CCS3. Yeah. Okay. So now CCS3, that single CCS3 was of 2 short scenarios. So I would be discussing about the first scenario. Again, that was mountain biker in a hot weather, went to the like biking, and during that mountain biking, he consumed around 8 liters of water, and that ended up in electrolyte derangement. We all know. So these are the typical presentation. So you have to know that electrolyte derangement, how you have to manage. So it could be hyponatremia, hypokalemia. So the questions can come in either direction. Now, the second short scenario was related to subarachnoid hemorrhage due to aneurysmal bleed. Day 4 in ICU, they had showed CTPA image, patient developed shortness of breath, and in CTPA image, it was pulmonary embolism. You did the CT angio, patient developed vasospasm. Now, the post SH day 4 vasospasm, one of the complications, then cardiac complications, tachysubocardiomyopathy. Then there were again 2-3 other SH complications that were in the short scenario. So that finished the complete 3 CCS. The first CCS was CNS and CVS, if I would say. Second CCS was more of like surgical complications, blood transfusion, organ failure, organ support, Second, like no, you can say skin and subtissue infection. The third CCS again consisted of two short scenarios, one related to electrolyte derangement and the other one related to the post-SH complications. Now, moving further, there were certain clues from the examiners that the examiner shared with us that there was no timer in the CCS. So you don't know that when your time of 25 minutes or 30 minutes is going to be finished. So that is real like no concern from many of the examiners. In the CBS, you expect that it would be 10 to 12 minutes. So you can like no think of, yes, I have to answer 9 to 10 questions or 11 questions. So the pace you can like from beginning only you can fix in your mind that yes, 1 or 2 minutes per question maximum. But in CCS this time, there was no timer. So that is a little bit of, so you have to be little bit speeding up your like speed, like answers. Otherwise, what will happen? The third or fourth or fifth, you don't know how many clinical vignettes are there. So if there are 5 clinical vignettes, so definitely maximum 5 minutes per one clinical case vignette. So if you are not like getting slow in those clinical case vignettes, so maybe the fifth one or the fourth one, you will be missing 3 to 3 questions or like no complete clinical case vignette. That means you are like losing almost 20% of your marks. That is real concern. The second important point, what we gathered from our exam is no next vignette if you unable to answer the correct vignette. That means if the third clinical case vignette is asking about what would be your modality of choice and the answer is CRRT, but you are unable to understand the clinical case vignette and you are like unable to answer that. So maybe the CRRT is the answer in the case vignette 4. So they would not show you the clinical case vignette. That means you are not actually going in right direction. So the examiner feels that you are not managing it properly. So that would be a definite like 0 for that clinical case vignette. The third important point, what we again like got from our like feedback, is no clues given by the examiners. So be clear in that. Don't expect that the examiner would be giving you 1 or 2 clues or like no some like soft clues or something like that. And one of the examinee, she shared the like the feedback that they were having complete blank face. So don't expect that they would be agreeing to what you say or nodding their head. Yes, you are right, something like that. Don't believe or don't like expect that type of feedback from the examiner. They won't have any of the like no feedback at that point of time. Right. So these were the real-time information from the examiners. So moving forward, just for you to understand how the CCS normally flows, we have made up one like demo CCS. It is not a proper, like you say, the examiner what they expect, but yes, we tried to show you in this introductory class how the CCS normally being asked. So the CCS 1, first clinical vignette, you are called into emergency department to review a patient. He is a 28-year-old young man who sustained polytrauma with head injury 45 minutes ago. He self-extricated but did not have a seat belt used and the airbags were not deployed. He was brought in by ambulance. Initial vitals in the emergency department. Yes, he is tachycardic, BP is in the lower range, respiratory rate is around 24 per minute, saturation is 93% on room air, and on examinations, GCS is E3V4M5. On pupillary examination, bilateral 3 mm, briskly reacting to light, he was able to move both upper limbs, but there was visible hematoma on the right lower limb at the upper thigh and left tibial region. The right upper limb is externally rotated and he was unable to move it. He was taking shallow short breath and also was restless and agitated. So this is a typical trauma case, and these will be the like the initial vitals what the examiner has explained to you. Now the questions would be it can start with what are the guiding principles in the initial management of this patient. So you have to start what are the normal like management protocols or the principles in managing the trauma patient. So it would start with trauma primary survey, and you have to say in this order, or it has to cover, your answer has to cover these points. airway with C-spine precaution, breathing, circulation, disability, exposure. So you have to tell, and then you will get marks in this order. Now, the second question would be, what are the other investigation you send immediately after the primary survey? So now the apart from the trauma primary survey, here in the management part, you have to also tell about the resuscitation part, the initial investigation part, then secondary survey, definitive therapy or transferring to the trauma center, and documentation. So the question number 1 included the primary survey, resuscitation, investigation sending, secondary survey, definitive therapy or transfer, and documentation. And then the other investigation, when they would be asking, so it is particular what is relevant to this case. So x-rays would be, as the clinical presentation in the last line, the presentation was mainly involving the lower limb, so lateral cervical spine, along with that chest x-ray and pelvis x-ray, and you have to definitely tell fast scan. So if you tell about all the things, it would be 111. And then the blood investigation, apart from the x-rays, we need at this point of time blood gas, which would be like the ABG, hemoglobin, electrolytes, and amylase, if there is any hollow organ or like the solid organ injury in the right now this condition. So this would be the question 1 and 2. And then what constitutes the secondary survey? So we all know from the ATLS guideline, ample head-to-toe examination, and you have to exclude life-threatening injuries at this point of time. Then some further diagnostic tests apart from the basic test what we have answered in the first, like the slide, and you have to again reevaluate, so that you have to continue with the resuscitation and also exclude that why the patient is not improving with your correct management or current management. Now, after answering all these questions, the clinical case Vignette would like enter into that you have started like managing this patient, but 10 minutes post admission to the emergency department, his recorded blood pressure is now further deepening. That means it is now 70/40 from 90/60. And his GCS has also dropped to E1, V2, M3, but no obvious airway obstruction. Initial blood gas is attached here. There was surgical emphysema palpated on left side of the chest, and obvious skin contusion was well visualized as seen in this picture. Now, the ABG on FiO2 more than 0.9 on non-rebreather mask is pH 7.25, CO2 is 46 millimeter mercury, PO2 60 millimeter mercury, bicarbonate 16, lactate 3.6, hemoglobin 8.8 gram per deciliter, and base excess of -7. So definitely this patient is having acidosis, both metabolic as well as respiratory, and the organ perfusion is not happening well. So this patient is actually right now worsening. Now, they would be also showing you some of the images at this point of time, some of the investigation report apart from the ABG. So this was the chest X-ray. Very obvious finding here. Now, again, apart from this chest X-ray, they would be also showing you ROTEM. So if you are getting a trauma patient and you start with the fluid resuscitation, blood resuscitation, definitely you have to answer about the ROTEM or the TEG. So Dr. Sanant is having again like the one question about the ROTEM in the CBS. So here you have to know in detail about this ROTEM and like the TEG, because now either you are getting in the CCS or in CBS, one of the questions. So you have to know what do you mean by XTEM, what do you mean by FAPTEM, what do you mean by APTEM. So here the findings are written. Now, the questions should be coming from the clinical case Vignette 2. What is your differential diagnosis of shock at this point of time? So the smart answers would be, you have to know about what are the types of shock. So it could be hemorrhagic or hypovolemic shock due to bleeding associated with fracture, and there could be concealed bleeding at this point of time. Obstructive, the chest X-ray is suggestive of that. Tension pneumothorax tamponade. Cardiogenic, it could be cardiac contusion. And then neurogenic, neurotrauma, because there is also traumatic brain injury and spinal cord injury. So it right now falls into one of this type of shock. So you have to mention all these like 4 types then you will get 1, 1, 1, 1. Now, what is the next management plan? So whenever you are saying about the DD for your shock, so how will you manage or resuscitate? So no immediate need for intubation at this point of time. If you think that this patient is not like right now going into respiratory distress and arrest, and also there is tension pneumothorax, so better you have to stabilize the tension pneumothorax part first. So needle and thoracostomy and thoracocentesis, and followed by tube thoracostomy. So that would be the management plan right now. And IV fluid bolus, peripheral vasopressors to start with. At this point of time, you don't intend to go for central line, which would take some time, rather stabilizing the patient with the peripheral fluid resuscitation and needle thoracocentesis and tube thoracostomy. Then you have to send the blood for coagulation study ROTEM, empiric tranexamic acid. You have to, after stabilizing this patient, CT scan of the head, neck, chest, abdomen or pelvis, double contrast to rule out any vascular injury, and autogram once the patient is stabilized. So definitely you cannot send the patient right now. Definitely you have to need do all these things one by one serially, stabilize the patient, and then see if the patient is like once getting stabilized, and then you have to do all this the test to exclude any other injury. Now, based on the management, what you will be doing based on the report of our ROTEM. So the answer would be, what is the management plan for the ROTEM finding? So as this patient is having, you are seeing here, the CT is 2116, and again you are getting the FIPTEM is of like a significant problem. So you would be planning to transfuse immediate fibrinogen concentrate. I would be showing you one slide how you have to prepare in one slide or two slide about your management for the ROTEM finding or take finding. Cryo precipitate also is an acceptable answer. Now, based on the blood gas, what is your further management plan? Definitely, you have to intubate this patient, because this patient is not going to wait for you. So after doing this management for the tension pneumothorax and fluid resuscitation, yes, you have to plan for intubation and ventilation due to hypoventilation, and also stabilizing the airway. Now, coming to the clinical Vignette 3, patient was successfully intubated. Here is the clue. So if you are not answering the intubation part, what I was trying to say in my initial slides. So if you are not saying intubation and you are getting the third clinical Vignette that successfully intubated, that means you are losing very precious marks, because that is the plan of management, and the clinical case Vignette is based on the intubation only. The first slide is successfully intubated. So patient was successfully intubated and ventilated. Now on further clinical examination, the patient had unilateral dilated pupil. So you have to now understand where they are now moving. His vitals post intubation were heart rate is around 48 per minute, sinus bradycardia on ECG, BP 168/42. Post intubation ABG is right now PA 7.29, PA CO2 44, PaO2 120, bicarbonate 14, lactate 4.6, hemoglobin 8, base excess -8. Now, the CT brain at this point of time revealed the following. I would show you the CT brain finding. The neurosurgeons were notified and they planned for an urgent craniectomy with evacuation of hematoma. Now, the CT brain is at this point of time, you are getting like this. So it is an EDH. Now, what is your the immediate management plan? So it is a tier 1 treatment for the managing the ICP, hyperventilation to maintain the PaCO2 around 36 to 38, head up more than 30 degrees centigrade, sedation, analgesia, paralysis, hypotonic saline, and neurosurgery, evacuation of hematoma, which you have already done. So if the clinical case Vignette is not given, that you have to inform, or the neurosurgeons have been informed, and you are missing this important point, you will lose crucial points here. So you have to remember that surgical intervention at this point of time is also as important as the medical management. Now, case Vignette 4, patient has received a craniectomy, evacuation of hematoma. So again, the last point, if you are not saying neurosurgical intervention and you are getting the clinical case vignette in the first line itself that the patient has received a craniectomy with evacuation of hematoma, that means yes, you have again lost very important crucial points in your clinical case vignette 3. Now, and EVD was placed as ICP monitoring system. Pupillary signs were now normalized. 6 hours post return to ICU. Again, the patient had some or other problem. So it is again and again getting complicated. So despite your surgical intervention, 6 hours post return to the ICU, the EVD had consistent reading of 35 millimeter mercury for more than 5 minutes. He is already heavily sedated and paralyzed. That means they are excluding that there is no problem with that this patient is bucking up or like no, that the patient is actually out of sedation and paralysis. So that means there is some problem in the EVD management. So the question should automatically come in the next, that is what is your immediate management plan? So the answers would be suggested, confirm the reading is not spurious and EVD is not blocked. That should be the answer point number 1. Open the EVD to drain CSF, consider hypotonic saline, consider transient hyperventilation, discuss with neurosurgery and plan for repeat CT brain. So if you are answering like this, you would get all 1, 1, 1, 1. Now, what is your target hemodynamic parameter? Cerebral perfusion pressure. What is your target CPP? 60 to 70 millimeter mercury. What is your intracranial pressure target? Level less than 22 millimeter mercury as per the Brain Trauma Foundation. And what is your anticonvulsant of choice? So levetiracetam or phenytoin. So these are the rough idea about the CCS what we have framed for you. So this would be flowing in this direction. The patient presented with trauma, but ending up with typical CNS case. So trauma plus CNS. We cover 2 domains in this. So at this point of time, any questions for the flow of the questions, how you should answer? The detailed the domain discussion would be in our course. The second, the domain in the flow, the first one is cardiology and cardiac surgery when we will be starting our course. The second one is trauma and toxicology, and the third one would be neurology and neurosurgery. So we would be keeping all like detailed discussion about the neurology, neurosurgery in that. Here we are not going into detail of the theory discussion, rather the idea is to show you how you should like answer in the real exam, and also how the questions normally vary from like one clinical case vignette to the other clinical vignette. Now, when we'll be discussing about trauma, the probable areas or domains, primary survey, secondary survey, you have to be very clear. Trauma scores you should know, initial management plan, system specific management. So it's not a broad heading of trauma. So it can also localize to the chest trauma, it can localize to the limb trauma, it can like localize to the spinal cord trauma. They can ask you a specific domain of trauma. Now, what would be the interventions you would be like preferring? That again would be a preferred question and like a favorite question by the examiners. Imaging, they would be showing you just like in this like clinical case vignette, I have shown you like the chest X-ray, and they would be also showing you focus finding, real like ultrasound echo findings, X-ray, CT scan, investigation as I have shown you, ABG, TAG, ROTEM. So these are the favorite like the questions that would be coming in the trauma. Now, the trauma would be definitely revolving around massive blood transfusion, trauma-induced coagulopathy, lethal triad, damage control resuscitation, permissive hypotension, DIC, minimal invasive interventions like Reboa technique. Then the trauma, if the patient is right now ending up with like not recovering, communication or counseling, documentation, medical legal things, prognostication to the family. Then again, every domain would be revolving around the recent landmark trials. So they would be ending up with a landmark trial. Like in this case, the decompressive craniotomy. So they may ask you what are the like the trials that have shown that it would be improving the mortality or improving the MRC score. So again, you need to know, you need to be thorough. Now, these are some of the, again, like the CT finding they can ask. You can see here in the CBS, like subcutaneous emphysema, massive subcutaneous emphysema with tension pneumothorax with like the chest trauma. Here again, the splenic laceration with hemoperitoneum. And TAG, I am not going to detail. Dr. Sanant would be discussing in the CBS part some or other like this type of questions. But yes, the Rotem patterns. So you have to remember in 1 or 2 slides about the exam specific questions. It is a common Rotem pattern on the basis of the glass, on the beer glass, wine glass, champagne glass, test tube, inverted martini glass. Not going into detail. In the traumatic brain injury, which was another part in my clinical case scenario, the questions can come from management, brain trauma foundation, imaging, ICP management, surgical interventions, minimal invasive like interventions like EVD, the trials related to traumatic brain injury, brain death. Very important. This time the examination question in one CCS, it was completely related to brain death prognostication, then DCD trials, everything related to this. So with this, I am ending up with the CCS discussion. Yes,
Actually, in the once in exam, they asked me about the renal replacement therapy. So as we all know, in ICU, there are only few indications to do urgent renal replacement therapy, like medically refractory hyperkalemia and uremic encephalopathy or coagulopathy, or in case of the pulmonary edema, which is not responding to diuretics causing hypoxemia. In my patient, there was nothing of those. So then I said there is no need of urgent renal replacement therapy. And even the literature has suggested early versus late RRT has no, like it does not affect the length of stay or ventilator days or anything. In that way, I told there is no urgency since urine output is still coming and he is not hypoxemic, electrolytes are fine, then we may not need to start RRT. But in the follow-up Vignette, they said, okay, we started RRT. It means I lost the marks there.
Again, the normal protocol is you have to answer in the right direction. So if the examiner is thinking that, yes, you should do the renal replacement therapy at that point of time, and if you are not telling, and the second or the next clinical case Vignette is starting with that, the RRT, yes, that would be little bit of not answer fetching. Yeah.
No,
Yes.
but how you will say how he wanted, because there was no clinical indication for doing renal replacement therapy at that point of time.
Yeah, difficult to say.
It can be like that. The CCS may be framed like that. So sometimes it may be unrelated thing. So
okay.
as I was saying, a general any clinical scenario ending up in a brain death scenario is not practically possible always, but I think most of the cases for CCS they ask are real cases in their ICU, in European ICU. So, but it may be it may be a question they wanted to ask and may not be related, and they have given you a hypothetical situation saying that suppose the CRRT started in this patient. So they wanted to ask you about the CRRT.
Maybe. And after that, they went into full details of RRT.
Yeah, so probably
like
that's what may have been
everything.
may have been the thing.
Okay, thank you.